Hello and welcome. My name is Dr. Brian McClelland, author of Marketing Dentistry Kaizen Style, available at www.dental-marketing.org. Today, I would like to go over an article from the Journal of Oral and Maxillofacial Surgery. This is from 2011. And the title of the article is Risk Factors Affecting Postoperative Hemorrhage After Tooth Extraction in Patients Receiving Oral Antithrombotic Therapy. It's written by Morimoto and Niwa and Minamatsu. So the purpose of this investigation was to see what the risk factors were that were affecting the onset of postoperative hemorrhage after tooth extraction in patients receiving antithrombotic therapy. So in the preamble, they discussed that during tooth extractions in patients receiving oral antithrombotic therapy, continuous administration of the maintenance dose of warfarin and or platelet therapy is recommended. When warfarin was discontinued for tooth extraction, the incidence of severe thrombosis was 0.95%, and most patients showing this event died. So with a complication rate of close to 1% and the complication being death when stopping antithrombotic therapy, naturally the recommendations currently are to continue with the antithrombotic therapy. But we do know that, and we do know with the discontinuation of aspirin, the incidence of cerebral infarction increases multiple fold, 3 times or greater as compared to with continuing the therapy. Also, the incidence of postoperative hemorrhage in patients receiving warfarin therapy has been estimated between 2 and 26%. There are hemostatic countermeasures that were retrospectively investigated in this study. So in this study, they had a total of 382 patients. This was done between April of 2002 and March of 2009 in Japan, in Osaka, Japan. Patients with hematological disease or liver dysfunction were excluded from the study. Furthermore, in patients in whom postoperative hemorrhage developed, the age distribution, the time of onset of the hemorrhage, the INR values at the time of tooth extraction, and the postoperative hemorrhage and local hemostatic measures were evaluated. So in all patients, platelet counts were greater than 10 times 10 to the fourth. Acute inflammatory findings were defined as a patient having pus, swelling, redness of the soft tissues around the tooth to be extracted, or strong percussion pain in the tooth to be extracted. If the patient had at least one of these findings, then they were considered to have acute inflammation. In such patients, tooth extraction was performed after administering 1 week of antibiotics. Analgesics were prescribed and include loxaprofen, that's Loxoprofen, or acetaminophen. Loxaprofen is a non-steroidal that is not available in the United States, but has been shown, when I looked it up, actually it prolongs warfarin, and because of its antiplatelet component, will prolong the effects of or antagonize the effects of the antithrombotic therapy. The fact that the patients were prescribed this was not delineated which patients were and which weren't, but could be a major reason for the incidence of postoperative hemorrhage that they had. Same oral surgeon performed all of these procedures. After the extraction, the teeth were packed with oxidized cellulose or Surgicel. Horizontal mattress sutures were placed with 4L silk. If there was bleeding points in the soft tissue, they did cauterize those with electrocautery when necessary. They did not prescribe tranexamic acid, which is one of the current recommendations in the United States because it has not been approved in Japan for use. So the results, 238 men and 148 women were in this study. Warfarin monotherapy was administered to 188 patients. Warfarin and antiplatelet therapy in combination were given to 66 patients, and a total of 128 patients had antiplatelet therapy alone. Acute inflammatory findings were present in 91 extractions and absent in 342 extractions. Postoperative hemorrhage occurred in 17 extractions for an incidence of 3.9%, so roughly 4%. So in analysis, 9 patients of the 17 that bled afterwards were receiving warfarin monotherapy. 6 were receiving the combined warfarin antiplatelet therapy, and 2 were receiving the antiplatelet therapy alone. There's no significant differences existed among the age groups. The onset of the postoperative hemorrhage ranged from 1 to 10 days, but for most patients was within 6 days. The one patient that was the outlier actually had an oral antral communication, so due to this should probably be disregarded. And so maybe a take-home pearl from this is that if you're going to have a bleeding incident, it's typically going to occur within 1 to 6 days after the surgical procedure. The INR values were markedly prolonged post-operatively in the complication groups, and local hemostatic measures and correcting INR values with vitamin K was done to help those patients in whom their INR values were greatly elevated. Among the 15 patients receiving the warfarin therapy, the INR at the time of tooth extraction ranged between 1.5 and 2.96, so basically less than 3. 7 of the 12 patients showed an INR greater than 3 when they had their complication and their bleed that required an intervention. It would be very interesting to know which of those were receiving the non-steroidal anti-inflammatory. As for the local hemostatic measures taken at the time of postoperative hemorrhage, among the 15 patients receiving warfarin therapy, hematoma removal, compression, placement of Surgicel, and resuturing were performed in 12 of those patients, and electrocautery and/or splint placement was used also in 6 patients. In the 2 patients receiving the antiplatelet therapy, hemostasis was obtained by compression alone and did not require any additional surgical intervention. No severe hemorrhage requiring transfusion was seen. So, out of this large number of patients, although there was some bleeding complications, none of them required transfusion therapy. The incidence of postoperative hemorrhage was 8.6% for surgical tooth extractions and 7.7% for acute inflammation patients. So in the discussion, the incidence of the total postoperative hemorrhage was 3.9% and was significantly higher for surgical tooth extraction and for those with acute inflammation. As far as local hemostatic measures were concerned, many patients receiving warfarin therapy required not only hematoma removal, compression, and Surgicel placement and resuturing, but sometimes electrocautery and splinting. Special attention must be paid to hemorrhagic events that occur within 6 days, since this is when the vast majority of the surgical events that or the hemorrhagic events that required surgical intervention occurred. The INR values at the time of postoperative hemorrhage was prolonged and greater than 3 in about 60% of these patients. The warfarin dose adjustment and vitamin K administration were required in addition to local hemostatic procedures. And the INR values are known to increase after tooth extraction and antibiotics and nonsteroidal anti-inflammatory drugs, and could have been the reason for all of these findings. For patients receiving antiplatelet monotherapy, hemostasis was obtained with compression alone. So the bleeding tendency is thus far more likely for warfarin and more likely to require local hemostatic measures. Tranexamic acid mouth rinses, which are recommended to be 2 minutes per time for 4 times per day, is recommended for the first 2 postoperative days to control excessive bleeding, but was not available in Japan. So I think this article was a useful addition to the literature and will be helpful for those performing surgical extractions on patients receiving anticoagulation therapy. If you have any questions, please feel free to email me at info@dental-marketing.org. Also, feel free to go to the website to see presentations on Kaizen, a business process, on 7 secrets of dental marketing, on abutment selection in dental implants, on dental implant terminology, on bisphosphonate-related osteonecrosis of the jaws, and an update on that, and many other presentations. Thank you. Again, this is Dr. Brian McClelland, author of marketing dentistry Kaizen style. Small steps to big profits. Thank you.